with cataract. Next, we move on to the next session. I would like to invite Elizabeth ma'am. She would be talking on visual rehabilitation after congenital cataract surgery.
Good afternoon, everyone. I'll be talking on visual rehabilitation after congenital cataract surgery. So, visual rehabilitation will all depend on the critical period. You know, the visual development will be permanently disrupted if deprived of normal stimulation in the early months of life, leading to amblyopia. And human critical period for visual acuity loss is only 6 to 8 weeks of life in congenital cataract and in corneal opacities. So, bilaterally visually significant cataracts should be done between 6 to 8 weeks of age, while unilateral visually significant cataract should be addressed even earlier, that is between 4 to 6 weeks. And visual rehabilitation after congenital cataract surgery is done by one of these, either contact lenses, intraocular lenses, spectacles, or later in life refractive surgery. See, this child has got a bilaterally significant cataract. The child is only 6 weeks of age. What should we do? We have to operate the patient as early as possible at the age of 6 weeks itself. The preferred surgery is lens aspiration with posterior capsular rhexis and anterior vitrectomy without IOL. Mind you, this is a bilateral cataract. The child is only 6 weeks. So, we usually do not put an intraocular lens. And visual rehabilitation is done with contact lenses at least till the child starts walking. When the child starts walking, you can shift to spectacles and secondary IOL later. That was about bilateral cataract. What about a uniocular cataract? Uniocular cataract in the very young, whether to do a primary intraocular lens implant or secondary intraocular lens implant, the controversy is still there. But many more and more people are doing intraocular lens implantation in the very young age if there is only monoocular cataract. But when the child comes in an older age like this, if the eyes are straight, if there is no strabismus, then the prognosis is very good. You can do a primary intraocular implantation and the results will be very good. But if there is fixation defect or if the eye is strabismic, then probably this is of long duration and the surgical result may not be very good because amblyopia would have been set in. So, if the child is above say 1 year, the preferred surgery is lens aspiration after an anterior capsular rhexis through a bibiennial irrigation aspiration cannula. First we do the incision, then capsular rhexis, and then lens aspiration. You do not need any phaco energy, there is no need of phaco probe. With the irrigation aspiration cannula, we can do a nice lens aspiration. When the aspiration is complete, you should do a posterior rhexis and then an intraocular lens can be implanted. A single piece acrylic lens can be implanted in the bag. In the bag position is always superior. Try to do in the bag introduction of the IOL, and it is important to suture the wound, unlike in adults. In adults we do not suture the wound, but in children you should always suture the main wound and the side ports. Primary IOL implantation versus secondary implantation. In primary implantation, the challenge is IOL power calculation and unpredictable postoperative refraction. And whereas when you think about secondary implantation, the surgery is easier but the risk of amblyopia is there, and compliance to contact lens wear is again a problem. So, you have to assess each patient and give individual merit and then you decide. When you put contact lenses, the problem is compliance. If you think that your patient is compliant and patient can come frequently, then go for contact lenses and secondary IOL later. The advantage of contact lens is that you can change the contact lens when the refraction changes, and you can give spectacles later. When you put a primary IOL, the problem is myopic shift. That is, there is uncertainty in the long term refractive changes, and there is increased risk of membrane formation, etc. See, this is the contact lens we usually give in our hospital. Extended wear contact lens, which is a soft silicon hydrogel lens. This is locally available. These lenses can be put 3 days consecutively, 3 days and 2 nights, and 1 night we give off without contact lens. This is the one which we use, and it's locally available, and it is very good. And when you give contact lenses in aphakia, you always, in the very small child, preschool child, you overcorrect at least by 2 or 3 diopters, because for them near vision is more important than distant vision. And after 2 years, you aim the contact lens or spectacle for emmetropia, and when the child starts going to school, give a bifocal with a +3 addition. And when do you give contact lenses or glasses? After surgery. It has to be done very early. Means aphakic babies refractive correction should be done in the first 2 weeks after cataract surgery. Usually we delay. The patient comes after 1 month, 1.5 months, you are reluctant to put contact lenses, and you lose the big precious time. So we have to put contact lenses 2 weeks after congenital cataract surgery. And older pseudophakic children can wait, of course. See, I would like to invite your attention to the infant aphakia treatment study, which compared contact lens with primary IOL implantation in the younger age group. And the infant aphakia treatment study didn't find any statistically significant difference in the vision in the 1 to 6 month age group after 1 year follow-up in those people with contact lens or with IOL. But the complications are more in the IOL group. This I have already shown. So, in addition to all these things, long-term monitoring is very important. We have to do multiple refractions, look for complications like glaucoma, retinal detachment, posterior capsular opacities, and strabismus. As Dr. Meena has already said, many of these children will go into strabismus. And the most important reason for strabismus, one, the child may be hypermetropic, and the child may go into accommodative esotropia. That's one reason. Another is amblyopia. If there is a difference in the vision between the two eyes, again it can go into strabismus. What about multifocal IOLs and EDOF IOLs in children? What I would say is that it's a cautious optimism. Larger studies and longer follow-ups are required before deciding on multifocals and EDOF IOLs. But nowadays, more and more people are using these lenses in a child who is more than, say, 3 or 4 years. But the problem is, these children will have a difference in the refractive power, and anyway they need spectacles. Then why don't you give spectacles instead of EDOF lens? That is the argument behind that. And we have to address the question of amblyopia also. When you think about the management of challenges of vision therapy and vision rehabilitation in congenital cataract, amblyopia can be due to stimulus deprivation, form deprivation, and ocular rivalry. In case of unilateral cases, patching regime is more stringent than what you do in strabismic amblyopia. In infants with unilateral cataracts, patch on the unoperated eye, 1 awake hour per month of age. That means a 1-month-old child should have 1 hour occlusion if the child is awake, and a 3-month-old child should have a 3 hours occlusion. A 6-month-old infant should have a patch of 6 hours in the good eye. And after 8 months of age, the dictum is you occlude 50% of the waking time. That is the patching regime. One has to be very careful about this. The patching regime in congenital cataract is more strict and stringent and more prolonged than in strabismus. Occlude the fellow eye at least 50% of the waking time. This is the recommendation published in European Journal of Ophthalmology 2007. And after occlusion, you can have some stimulation with flashlight like this, and in an older children you can resort to other forms of vision stimulation exercises including binocs. And one word about myopic shift in pseudophakia. Nowadays when the refractive power myopia increases in children, we give this low dose atropine, and the effect of low dose atropine in pseudophakic myopia is not established. And usually we don't give atropine for the progressive myopia in pseudophakic children, but of course if you can monitor and document that the axial length is elongating, probably you can have a trial, but this is not proved. And role of refractive surgery, both PRK and LASIK can be done to correct postoperative myopia in older children. And when the child is older and the patient has gone into myopia, you can have exchange of IOLs, or you can have a piggyback IOL inside the eye. And one word about the visual outcome, even in the best centers. Even in the best centers, 6/18 vision in a congenital cataract operated is supposed to be good. And I would like to say one thing, that there was a large study done in the blind schools of India, and in Indian blind schools, more than 50% of the children who are blind are due to either bad congenital cataract surgery or unoperated cataract surgery. That is an eye opener for us ophthalmologists. One take home message, the most important thing is you have to diagnose congenital cataract as early as possible. So the red reflex test in the newborn nursery is most important thing to detect congenital cataract as early as possible and do the surgery as early as possible. Delayed surgery result in amblyopia, nystagmus, strabismus, and optical correction I have already discussed. Just remember that amblyopia, aphakia is as amblyogenic as cataract. Those infants who undergoes aggressive treatment will attain good visual acuity. Thank you very much for a patient hearing. Thanks, sir.
Thank you, Dr. Elizabeth, for that wonderful talk and stressing upon the importance of